Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
As we reach the end of May this weekend, we're wrapping up American Stroke Month. And today we'll take a look back at the history of stroke treatment and the improvements that have been made in not only how we treat stroke, but in recognizing stroke earlier and seeking help more quickly, which is critical.
Joining us on the phone from Jacksonville, Florida, is Mayo Clinic neurologist Dr. Thomas Brott. Dr. Brott began practicing medicine in 1978, making this his 40th year of treating patients. In 2017, the American Heart Association awarded Dr. Brott the Research Achievement Award for a distinguished lifetime of scientific achievement in the field of cardiovascular research. Welcome to the program, Dr. Brott.
Thanks, Tracy. It's a delight to be on.
So, Dr. Brott, good to have you with us. You have obviously been at this for a while, that is, seeing patients who have stroke. How did you get interested in the field?
Believe it or not, through Mayo Clinic. I came to Mayo Clinic in 1973 as a medical student from the University of Chicago. And lo and behold, my teachers were absolute giants in the field, Bert Sandock and Jack Wisnant. Mm-hmm. And during that summer fellowship, the CT scanner was introduced for the first time in the world at St. Mary's Hospital in Rochester, Minnesota.
So that was about 1970, what was it?
1973. That's
wow.
45 years ago. And for the first time, we could see inside the brain, and we could see a brain hemorrhage versus a stroke caused by a blockage, which was a true revolution in stroke medicine.
And how long have you been in Jacksonville?
I've been here for 20 years.
And was that when it opened?
No, it opened about close to 30 years ago.
Oh, my gosh, really? So where were you prior to that?
I was at the University of Cincinnati. That's where I began practice, actually in private practice for 3 years, and then at the university for 17 years.
All right, so tell us about the advancements that you've seen during your career, particularly with regard to not only diagnosing but treating patients with stroke.
Well, to treat, first we had to be able to diagnose and diagnose quickly, and the CT scan allowed us to do that. 1 in 6 strokes is from bleeding, the hemorrhage. 5 out of 6 are from a blockage. So if you use a clot-busting medicine, you can't use that in the 1 out of 6. It would be truly Russian roulette. So the CT scan was key.
So the difference being that with the CT scan, you can tell what type of stroke it is, and then you know what the appropriate treatment is.
Absolutely. And technology came right into it. At that time, in the 70s, we had recombinant biology, which allowed us to synthesize TPA that we all make, but synthesize it and then test it. The other technology were cell phones, where we could have communication with the hospitals and doctors so that we could deliver a clot-busting medicine and do it within minutes.
So TPA is the clot buster?
Yes.
And so if somebody has the typical kind of stroke, the most common type of stroke, a blood vessel in the brain gets clogged, you put a catheter up there and unclog it, break up the clot.
Well, that's what we do today. That's the advance of endovascular intervention. To begin with, we gave it by the vein, where the concentration of TPA would be 2,000 times what we make with our own bodies. For the smaller clots, the clots that, let's say, are almost 911 clots, but not quite, those types of strokes were treated very successfully with TPA in the late 70s and early 80s.
Tell us a little bit more about that clot-busting medication, because I didn't know until we were preparing for this interview that you were one of the lead investigators in the clot-buster medication.
But the first patient to be treated for stroke was with TPA, was treated in 1987 at the Christ Hospital in Cincinnati. And we were lucky enough to have a network of 12 cooperating hospitals. And by using cell phones, paramedics, EMTs, we had a coordinated system that allowed us to take advantage of what we hear today, time is brain. Every minute counts. So we had a small, compact city, and we had the right biology, the right diagnostic technology with CT scan, and the right communication system. So it kind of came together.
So what made you think that TPA would work?
Well, we knew it worked in the heart. It had been approved by the FDA in the heart, so it opened up the clots that cause heart attack. So it wasn't a stretch to then think it might work for the brain. Now, as you know, Tom, TPA was actually, a stroke was a contraindication early on because of this fear of hemorrhage. But with CT scans and the ability to look at patients carefully, we could sort out the right patients.
So in other words, if you gave TPA to a patient who was having the uncommon type of stroke, the bleeding type of stroke, you would actually make them worse.
Much worse, if not cause their death.
All right, but now by doing the CT scan, you can tell what kind of stroke it is and whether or not you ought to pursue the TPA.
Right, and the advances in technology, CTA, computed tomography, angiography, MRA, magnetic resonance angiography. Now these new technologies, we can see the clot and decide, well, is TPA enough, or do we need to use that catheter that you referred to and go right up into the brain?
And how quickly does this have to happen in order to reverse a stroke?
Well, I'm pleased to say we used to think you had to do it within 90 minutes, then within 3 hours. Today we have studies that show that you can go out to 24 hours in patients with clots who have good kind of collaterals or blood vessels coming in from other parts of the brain. So it's not too late for the stroke patient at 12 hours or even a little later.
Now that's the
if
first
they've
time
got
we've
good
heard.
collateral.
Oh my gosh, fabulous!
If you could have heard that news back when you started in the 70s, would you have believed it?
Well, I probably would have. We knew that these collateral blood vessels. Remember, this is not everybody. It's still time is brain. So let's say somebody has a stroke.
Sure.
They're paralyzed. They're on the kitchen floor. Every minute counts because you don't know. Is that a patient with good collateral circulation? In other words, blood vessels coming in from other parts of the brain. You don't know that. So you've got to get them to the hospital immediately. You've got to evaluate them immediately and decide, is this for IV TPA through the vein, or do we take this person to the cath lab?
We were speaking at the beginning how we're wrapping up American Stroke Month. Why is it beneficial to have this month recognized?
Well, mortality has gone down really miraculously in 30 years, 40%. 40%. That's remarkable.
Has gone down.
And it's gone down
Wow.
because we're not smoking, we're taking care of lipids, we're exercising, we have new medicines for atrial fibrillation, we have better medicines, antiplatelet medicines than we ever had before. So that's a miracle. But yet in our current study in CREST-2, where we look at carotid disease, 40% of the patients from the best medical centers in the country are coming to us and their cholesterol is too high. 30% are coming to us, again, from the best hospitals in the country, and their blood pressure is too high. So the kind of the message, whether it's prevention of stroke with atrial fibrillation, to be on the right medicines, taking care of your blood pressure, taking care of your lipids, those messages need to get out there, and Stroke Month helps us carry that message to the people that need it.
Finally, we have about 30 seconds left. How does it feel to receive a Lifetime Achievement Award from the American Heart Association?
Well, these awards go to one person, but you can imagine with stroke. It starts with the person's spouse calling on the phone. My husband's paralyzed. The EMT, getting him to the emergency department, calling the stroke team, getting him to the catheter, the cath lab. You know, and then one person gets the award. Yes, it's wonderful, but it is a team.
Well, congratulations, and a well-deserved award. And it's so good to know that we've got up to 12 hours to potentially reverse a stroke, and so much progress has been made during your lifetime.
Thank you so much. And for some patients, even 24. But every
All right,
minute
we're stretching
counts.
it now.
That's
wonderful.
right.
We're wrapping up American Stroke Month with Mayo Clinic neurologist Dr. Thomas Brott. He has seen marked improvements in treating stroke over his 40 years of practice. Thanks again, Dr. Brott.
Thank you.